chat. Okay, so good afternoon all of you. I guess I'm connected and we are going to discuss GIT and urology. 25 questions as predictor of NEET. Dekho, before I start, I'll tell you a few points. First of all, it's not possible for anyone, it's not humanly possible to give you 25 questions and to say that question will come from this only. It's basically making fool of you if someone says like this. So rather than 25 questions, I'll discuss the whole topic briefly, of course, and I will also discuss the associated topic, adjunct, like anything related to this. So at the end, we are not discussing 25, rather we discuss more than 60-70 points. Number 2, of course, I have taken DVT, rapid revision, Predictor, fast revision, etc. So same thing we have discussed again and again and again. So I'm sure many of you have attended all this many times. And thirdly, I will not finish at 4. It's not possible to discuss 25 question and topic and make you understand and finish at 4 in 1 hour. So I may go, I'm planning to stop before 4:30, finish before 4:30, but definitely I'll go beyond 4. So it will be around 4:20, 4:30 will finish. And lastly, GIT part I cover, all of you have attended lecture, regular batch, all this. Urology I only discuss at some centers. So maybe urology will be new for you, so I'll try to cover more urology. So let's start with a GIT. 50-60% discussion will be same. What we have discussed in GIT in so many discussions. Some topic will be new. Basically, it's kind of a revision. But urology, of course, will be new for most of you. So, one question pattern is this, where they give you some clinical sign, symptom and ask the diagnosis or investigation. So, a 70-year-old male complaining of dysphagia in the neck. I'm sure all of you know this concept. Halitosis. देखो आप main point क्या है? Main point है number 1. Dysphagia in the neck, cervical dysphagia and old male halitosis. So diagnosis is Zenker diverticulum, and for Zenker what we order? We order barium swallow. So I don't think there's any confusion in this kind of question. Now Zenker already I've discussed many times. Zenker is a weak triangular area called Killian dehiscence between thyro and cricophalanges here, and outpouching from here is called Zenker diverticulum, outpouching from Killian's dehiscence, and seen in old male, diagnosed by barium and treated by diverticulectomy and cricopharyngomyotomy. Now see another, so this is basically the Killian's dehiscence between thyro and cricophalanges directed backward and outpouching here, and this is the barium, one of the very important barium for your exam, barium swallow. Okay, now a similar question with some tilt, some twist. A old male again, but see, he is firstly he is a chronic smoker, secondly he is having weight loss and the dysphagia starting from solid. So here the diagnosis will differ, and here most likely the diagnosis is cancer. And because I suspect cancer, my first investigation should be endoscopy and biopsy. If the dysphagia was very severe and complete or in the neck, then I would have gone for barium again. But here it is endoscopy. Okay, I guess you are following very simple concept. Thirdly, a young female dysphagia for liquid. This is achalasia cardia. So just by age, sex and symptom, whether dysphagia for solid or liquid, you can make the diagnosis. Regurgitation, halitosis, old male dysphagia in the neck, this is Zenker. Dysphagia for solid, progressively increasing, short duration, weight loss, smoker, this is cancer. Young female, dysphagia for liquid, achalasia. And here, of course, in barium, what do you find? Rat tail deformity. So these are the salient point about achalasia cardia due to absence of Auerbach inhibitory fiber. Remember, Meissner's plexus called submucosal plexus are not involved here. Only and only Auerbach plexus are involved, which is also called Meintrick plexus, and inhibitory fibers are involved. Secondly, the age is young, dysphagia more for liquid. Of course, you can have this in male as well. The the ratio is almost equal, but slightly more common in female. So in question they can give male also, but in general slightly more common in female. And dysphagia for liquid. VIP is not main chemical mediator, nitric oxide is the main mediator, and this is the area where you get cancer, squamous cell cancer. So this is the area which is disease. The green part is the disease part having no ganglion, but the cancer is not seen in disease but seen in dilated proximal part, which is squamous cell cancer. And X-ray shows bird beak sign, rat tail sign, and sigmoid esophagus. Manometry is gold standard test. Generally, if someone asks what you order in achalasia, you will say manometry, that's a gold standard, but in practice, first prescription is barium. And treatment is Heller's myotomy and POEM, which is per oral endoscopic myotomy. And these are 3 X-rays: bird beak sign, rat tail sign, and sigmoid esophagus. Rat tail sign we also get in cancer, but in cancer, the rat tail is irregular and serrated. In cancer it's irregular and serrated, and here it's smooth. Now, this is the corkscrew appearance of DES, diffuse esophageal spasm, very commonly asked image. A newborn child has been referred to the hospital from the primary health center with respiratory distress. X-ray chest of the child shows the following finding. Now you know what is the diagnosis. You can see number 1, heart on the right side. Number 2, intestine lying in the thorax. So it's a congenital diaphragmatic hernia on the left side. In another word, Bochdelic hernia. So diaphragmatic hernia more common left side is right. Patient present distress is right, because bowel is in the thorax, lung doesn't have space to expand, and lung even has not developed. So this respiratory distress is very common. Bag and mask ventilation is any pressure ventilation is contraindicated. So the best answer is D. This is the answer. Why? We don't do immediate surgery because the lung is immature. Normally we do surgery late after 1 week. So surgery done after 7 days. These are the point. This is the foot end view. This is right and this is left. So this is the Bochdelic hernia, left posterior. So Bochdelic hernia left side is more common, 95%, called Bochdelic, right side rare. Morgagni hernia only 5%. Colon is the most common content of Morgagni, very commonly asked. Presentation is flat abdomen because the bowel is in the thorax, heart on the right side, and respiratory distress. Cause of death is pulmonary hypertension and pulmonary arterial hypertension and pulmonary hypertension, which is MCQ. No pressure ventilation is absolutely contraindicated. Sombo bag mask ventilation is contraindicated. And treatment is repair is always done from laparotomy, never by thoracotomy. Repair is done late after 7 days. And size of defect in thymus surgery does not affect the prognosis. So normally we do late repair by laparotomy, not by thoracotomy. And the common hernia is left posterior lateral, called Bochdelic hernia, 95%. Rare is right anteromedial Morgagni, 5%. Presence in adult, colon is the main content. These are 2 X-rays of diaphragmatic hernia I want you to remember. Now this question was asked this year in January, FMGE. Which of the following is primarily, what's the main use of this imaging modality? First of all, what is this imaging modality? This imaging modality is endoscopic ultrasound. And endoscopic ultrasound is done to detect T and N stage. So it is for the staging. And if I ask, what is the best investigation to only see the metastasis, then you would say 18 FDG PET scan. And overall for staging, CECT, PET CT or CCT. So this is a esophageal ultrasound done through the esophagus, and it is done to detect node and stage. So node and depth. So this is the best answer. And these are the 5 layers of endoscopic ultrasound. First one, see here, is white, which is superficial mucosa, black is deep mucosa and musculus mucosae, white is submucosa, this black is muscle and white is serosa. The GIST gastrointestinal stromal tumor is found in layer 2 and layer 4, while adenocarcinoma, see here, this is the first layer, white, then black musculus mucosae, then white submucosa, then black muscle and white serosa. So, and adenocarcinoma will come from layer 1 only. A 20-year-old female patient consumed the sodium hydroxide, means basically cleansing agent lye, which is a alkali injury. She cannot eat anything. So what should be done for her right now? We have to do a feeding jejunostomy. Why not a stent placement? Okay, now I will, as I said, I'll tell you some basic points also. Dekho, how to differentiate a stricture on barium, whether it's a malignant stricture or a benign corrosive stricture, acid alkali stricture. Acid or alkali stricture will be long stricture. See, this is a long stricture, although they will be irregular, but not as irregular as cancer. So side by side you see, this is a long stricture, this is corrosive stricture. This is a short stricture, this and irregular, this is cancer. So this is how you can and of course history will tell you, but even in question, if they don't show the history, don't tell you the history, a long stricture somewhat smooth is corrosive, short irregular stricture is cancer. Now that's one. Second, in case after esophagectomy in cancer you have to reconstruct the gap, stomach is the best substitute. Stomach is the best conduit for the esophageal cancer after esophagectomy. But for corrosive and acid strictures, because stomach is also damaged, here we prefer jejunum. So for corrosive injury, caustic injury, chemical injuries, jejunum is the best substitute, not stomach. And jejunum. And colon can also be used, left and right both. Left colon is preferred because the diameter of left colon is same as of esophagus. So both have the same diameter, which is why left colon preferred over right, but all three can be used. Ileum is never ever used for interposition. Stomach is the best conduit, you can follow the shortest course of posterior intestinum, but stomach is not used here, which is I am trying to explain. Stomach is for cancer, not for strictures of chemical injuries. Third, Zargar classification is used for chemical injuries. Like it's very simple, like just erythema, edema is 1, partial ulcer 2, complete ulcer 3, gangrene perforation 4, but you don't have to go for that. And endoscopy should be done immediately. Some people used to say endoscopy should be avoided for the fear of injury. No. If you are doing endoscopy within 12 hours, then it's not a problem and it should be done immediately. Not late, not after 2 days, then we'll perforate the esophagus. So endoscopy is indicated immediately. Fourthly, esophagus gastric injury, alkali and acid. Alkali causes liquefaction, alkali causes necrosis of esophagus and depth-wise injury more. Acid causes coagulative necrosis, alkali causes liquefying necrosis. Acid causes coagulative necrosis, number 1. Number 2, stomach injury more rather than esophagus. And number 3, late injury due to Ishard. The slough forms, slough gets dislodged, then patient gets perforation. So here, late perforation are more common. Alkali, early perforation, stomach, late perforation. Acid, liquefying injury, and alkali, liquefying injury, acid, coagulative injury. Now, related to this esophagus, we have one more very favorite topic, and that's foreign body. I mean, last 3 years I am seeing question on foreign body in NEET, UPSC and FMGE. Let me wear my specs, I cannot see the chart. Okay, someone has written class started or not, so you have to go back and rejoin again. See, foreign body in esophagus is a very common topic. And there are 4 points we need to know. Number 1, how to differentiate foreign body in esophagus and trachea. Esophagus will have an end-on view, like if you take AP view, esophagus is like this, while trachea will have end-on view in the lateral view. So trachea in lateral it's end-on, esophagus it's AP, it's end-on. Number 2, how to differentiate button battery from esophagus foreign body coin. Button battery has double ring sign, like this, and this is the coin. So if it's important to differentiate because button battery need to be removed immediately, while for coin you can leave it there. Number 3, what is the protocol? Sharp foreign body, symptomatic foreign body, magnets, button battery and size more than 5 cm should be immediately removed by endoscopy. While a smooth foreign body and asymptomatic foreign body less than 5 cm, you can very well wait for 24 hours, keep under observation and get observation for 24 hours and then get the X-ray done. Now X-ray will tell you the new position. If the new position is still in the esophagus, remove it, or it's gone beyond pylorus, leave it. So foreign body which like here. So in this question, this number 1 foreign body is in the esophagus. And number 2, it's asymptomatic, there's nothing, he comes, so nothing is mentioned. So answer is just wait and watch. And for how long you wait? You wait for 24 hours. Why not laryngoscopy? Because it's not in the trachea. Heimlich, it's not in trachea. And endoscopic removal can be done after 24 hours if it's still stuck there. So, and these are the magnets. If you have an image like this, answer is immediate removal. Another question that they ask is, no, laxative are not given in esophagus, laxative is for bowel. Number 2, this question differs from the previous question because here the symptom is choking. It's not dysphagia, not salivation, not pain. Respiratory distress, so it's in the trachea. And here what you do, you have to immediately go for Heimlich maneuver. So, and if Heimlich maneuver means stand behind the patient, make a fist, grasp the wrist, make a ring and just compress epigastrium 5 times backward, upward, thrust forcefully. You'll push the foreign body out. So Heimlich maneuver is the best. So the question differs. It's in the trachea while the previous one that was in the esophagus. Okay, so here answer is Heimlich. Now this again is a very, most of the topic are what I have already discussed many times. Some topics are new, but urology will be of course new. A 3-week-old male having recurrent non-bilious vomiting, X-ray given below. So this is a single bubble sign suggestive of CHPS, considering the age, considering the non-bilious vomiting. Now there will be hypochloremia, which is less chloride. There will be hypokalemia, which is less potassium, and alkalosis, high bicarbonate. So best answer is D. So the points of CHPS you need to remember are: firstborn male child, that's more common. Erythromycin increases the risk. Projectile non-bilious vomiting 2 to 8 weeks after birth. Antenatal no problem. Olive-shaped lump, a olive-shaped lump in abdomen, and a left to right peristalsis. No protein energy malnutrition, no polyhydramnios, and ultrasound will be investigation of choice. What finding? This is the cervix sign. We'll discuss this. So ultrasound length should be more than 16 millimeter and thickness should be more than 4 millimeter. That's another question. This is a separate question. Target sign and antralipal sign and cervix sign are the ultrasound signs. This is stomach, this is hypertrophied pylorus, and this is the stretched pyloric canal. And string sign, mushroom sign, double track sign, caterpillar sign, and shoulder sign. These are the signs. Like this is the string sign, straight pyloric canal, and this is the mushroom sign. Okay, so this is what you get here. This is single bubble sign on X-ray. Well, CHPS, first thing is you have to correct the electrolyte imbalance, which is hypochloremic, hypokalemic alkalosis, and resuscitation before surgery. So always you consider as a non-surgical emergency. Very, very important point. Never ever go for surgery immediately. First correct the electrolyte imbalance, then you go for surgery. The fluid of choice is N/2 saline. Normally we give ringer lactate for dehydration, hypovolemia and diarrhea and burn and trauma. Ringer lactate, what happens? Lactate goes to liver, gets converted to bicarbonate. So ringer lactate increases all other conditions. We have acidosis, while here we have alkalosis. So ringer lactate increases the alkalosis, which should be avoided, not contrary, but avoided. Normal saline normally we give in adults. So any patient having gastric outlet obstruction, having alkalosis, we don't give ringer lactate, we give saline. While in children, neonate before 1 year, we prefer N/2 saline. And 5% dextrose and potassium should be given along with it. Potassium is given only after urine output starts. Don't give potassium before. So N/2 saline with 5% dextrose you should give, and add potassium also. So here the salient pointer, you have to remember the electrolyte imbalance, number 1. Number 2, remember it's not a surgical emergency. First correct the dehydration and electrolyte imbalance, then operate. Number 3, fluid of choice N/. Not only here, any gastric outlet obstruction, even in adult, acid as loss, so patient develops alkalosis. So here normal saline is preferred over ringer lactate. So once urine output is more than 1 ml per kg per hour, means dehydration has been corrected, then you operate, and treatment is Ramstead pyloromyotomy. Not pyloroplasty. Don't open the mucosa and lumen, just cut the muscle and that's it. Pyloromyotomy. Pyloroplasty is totally different surgery. Here you give milk after 6 hours and discharge within 24 hours. When in pyloroplasty, where we open the lumen, we keep the patient only for 2 days. Now, related question, this is a question of 2024 NEET. They have shown you the ultrasound, and like you see cervix sign with empty stomach and hypoparathyroidism and age, and this is CHPS. Now this is a question of July 2024 FMGE. This question showing single bubble sign and ask what electrolyte imbalance you get here. Again the answer is hypokalemia. Now this is a question of January this year FMGE. As I said, someone having only vomiting and gastric outlet obstruction, then acid, if the loss is from the small intestine, then alkali loss, then he will have acidosis. But gastric content loss, acid loss, he'll have or she will have alkalosis. So the answer is metabolic alkalosis because of only vomiting. Same question asked in NEET, a patient adult having vomiting with acid vomiting, he will have metabolic alkalosis. Why? From the stomach, acid is lost. Another question asked, this was a INICT question asked 10 days back. Now there are some points here. Dekho how they confuse you. They gave the age 6 week and non-bilious. Both are suggestive of CHPS. But in CHPS, all of us know what do we get? We get number 1 projectile vomiting and number 2 olive shaped lump. The lump may be absent, but you tell the mother to feed the child and always examine the abdomen after feed, preferably after vomiting. The moment you give feed, it's not like adult where gastric outlet obstruction causes regurgitant vomiting off and on. Here the child has vomiting immediately after milk and projectile, which is why stomach is empty and child is always hungry. So olive shaped lump should be there, peristalsis should be there, and projectile vomiting should be there. All these features are absent. Of course, this is a tricky question for you. I would say this is not tricky. This is an idiotic question. There's no point asking such kind of question and confusing you. This doesn't test your knowledge. But anyway, this was a question. So answer is GE. A small bowel obstruction has bilious vomiting Milk allergy will have other features as well, and since birth it's after 2 weeks. So best answer was A. A patient underwent surgery for just stomach, excision with 1 centimeter margin done. 1 centimeter is the same margin for gist. What is the best investigation to assess the recurrence? In one word, they are simply asking what is the investigation of choice for recurrent gist. Just one line. And the answer is PET scan, which is a neat question. It's a so the features of gist that you have to remember, it doesn't come from the mucosa, it comes from the muscle. Interstitial cell of Cajal, although it's written Kajal, so we'll say Kajal. GI pacemaker. Most common site is stomach and ileum. Most are positive for CD117 and Dodge1, detected on just one, which is most specific. Most common presentation hematemesis. All cancers go to lymph node, then blood-borne, but just first goes to blood-borne, not lymph node. This is a property of just that lymph node involvement is very rare, only 5% and late. So, and local invasion and blood-borne secondary to the liver is common here. So, blood-borne secondary to liver and direct invasion to omentum, pancreas and peritoneum, node negative. Remember, nodes are not positive here. Most are c-KIT positive while some are PTGF alpha positive. PTGF alpha has good prognosis. There are two types. This is a question again. Spindle cell is the most common type, 70%. Epithelioid is 30%, and pleomorphic, which is called mixed, is rarely less than 5%. Fletcher criteria is how you diagnose a gist is benign or malignant. Size more than 5 centimeter and mitotic index more than 5 per 50 hyperfield is malignancy. Now these are the question one-liner. IOC is CT scan, for recurrent gist PET scan, for biopsy EUS guided biopsy. Already we know it's found in layer 4 and 2. Why layer 4 and 2? These are the two layer which has muscle. It's coming from muscle. So these two layer having muscle just can come only from 4 and 2. And the surgical margin should be ideally 2 centimeter, but more than 1 is fine. Imatinib is the adjuvant drug, post-surgery drug. You give imatinib for recurrent gist or residual gist. What it does, it's a tyrosine kinase inhibitor, and all the gist which are c-KIT positive, only c-KIT positive, you can use this. Dose 400 milligram per day. Sunitinib is used for imatinib resistant gist, which is a PGI MCQ. Imatinib is used was the last year FMGE question. Mitotic index and tumor size is the main marker for indicator for prognosis, while in adenocarcinoma node is the main indicator for prognosis. Consumptive hypothyroidism is a phenomenon of gist is known to destroy TC-T4, so it can cause hypothyroid. Gist patient may have hypothyroidism called consumptive hypothyroidism. Now these three are relatively common, frequently asked: carnate, triad, diet and carnate complex. Carnate triad is non-familial, not coming from parents to children. It's genetic but mutation, non-familial. And three features of carnate and non-familial. Three features are gist, paraganglioma and pulmonary chondroma. Gist in the stomach is basically epithelioid time. You remember a few minutes back I told you most common is spindle cell. Here it is epithelioid, young female, second decade female. Carnate diet, number one is familial. Unlike carnate triad which is non-familial, it's familial. And number two, only paraganglioma and gist and no pulmonary chondroma. And carnate complex is a totally different condition where you have endocrine problem, mainly adrenal. Adrenal is the most commonly gland involved, and myxomas, heart myxomas, pigmented schwannomas and testicular tumor. So this is carnate complex. A patient was brought to the emergency with diffuse abdominal pain, abdominal wall rigidity. X-ray image is given below. This X-ray is a very, very favorite X-ray for you, and this X-ray is air below diaphragm. And I'm pretty sure you know the diagnosis, but there's one catch point here. The perforation is in the ileum. Yeah. So had it been, this is pneumoperitoneum, absolutely correct. Had it been omental duodenal perforation, then we would have gone for omental patch repair. Ileal perforation is treated primary closure by absorbable repair. Dekho, what all option we have here? Let's understand the question. It's single perforation, there's no need to do resection and anastomosis. I can simply close it primarily, I'll show you the image. Number 2, if there are multiple perforation, not possible, then I go for resection anastomosis. And number 3, the ileum is grossly diseased. Patient comes, okay, so I'll say it again because one of you have written why not resection anastomosis, so I'll draw it for you. Dekho, one perforation I will just close called primary closure. Multiple perforation or diseased bowel I can resect anastomosis. But if the like patient comes after 8 days, 9 days, 7 days, you open the abdomen, you find bowel is very unhealthy, fragile, friable, and you are scared that it will not heal, it will leak. In that case, what I'll do? I'll do a ileostomy, temporary ileostomy. So ileostomy is only done when the bowel is very, very unhealthy and the possibility of primary leak is very high. So all this option, all 4 can be done in different cases. So what are the features of peritonitis? Features of peritonitis are sudden severe diffuse pain. Diffuse pain. Number 2, the pain subsides after 3-4 hours, and not because patient is improving, but because the peritoneal fluid comes in the abdomen and dilutes the content. So, and that's a transient phenomena of less pain and inflammation called phase of delusion. Phase of delusion is a phase of improvement 3-4 hours after birth due to dilution by peritoneal fluid, which will only last for few hours. Guarding and rigidity, tight abdomen. I will tell you, I'll read the name first, then I'll tell you. I cannot read from here, it's very, I think it's Adyan or something. Anyway, I'll tell you the answer after finishing this. I'll tell you how to frame the question. So, guarding and board-like rigidity, absolutely hard abdomen. Guarding is voluntary and rigidity is involuntary. It's quite far actually, so I cannot read from here. Tenderness and rebound tenderness are very classical feature. Bloomberg sign, rebound tenderness. Abdominal pain and coughing called Dunphy sign. Small bowel sound will be absent, patient in obstruction due to loss of motility called ileus, that is due to perforation, peritonitis, and liver having air on top of it, so liver become resonant called masking or liver dullness. These are the features of peritonitis, while this is a feature of pneumoperitoneum. Now this is a air below diaphragm. The investigation of choice is X-ray. X-ray erect view, chest erect view. Okay, but what's the gold standard? CT scan. And in abdomen, the best X-ray, left lateral decubitus view. Left lateral decubitus view, which shows the air above ascending colon. This is air below. This is a very important X-ray, air below diaphragm. Now see, the signs of pneumoperitoneum other than air below diaphragm are, just remember the name, cupola sign, regular sign, Doge cap sign, falciform ligament sign, also called silver sign, inverted V sign, telltale triangle, and football sign. All these signs I have shown you. Gold standard is CT, of course. All these signs I have shown you in regular batch, but only air below diaphragm is important. And this sign also may come in exam, although chances are less. The bowel wall is visible because air is inside the lumen and outside. Like this is the bowel wall, and air is here, but now air is outside also, so in between wall I can see. So when the in between wall is visible, then this is called regular sign. And there's a regular triad for gallstone ileus. Regular sign and regular triad are different. So regular triad is gallstone ileus, where there's a stone in the ileum, dilated bowel showing obstruction, and air in the biliary tree, gallbladder and biliary tree called pneumobilia. So regular triad you get in gallstone ileus with stone in ileum, dilated bowel and air in biliary tree, while regular sign you get in pneumoperitoneum. I can see the wall of the bowel, that's called regular sign. And this is the omental patch repair. This is a duodenal perforation. Pass 3 sutures vicral, and then you put the greater omentum and tie the knot. This is omental patch repair. While this is the primary closure, this is the ileal perforation. You can see this bowel here and this bowel. Compare this. This is somewhat unhealthy. This is quite a normal looking bowel. This unhealthy bowel can be very, very severely unhealthy, like inflamed, fragile, fragile, bleeding. So that case's primary closure has a very high risk of leak, and then it's not prudent to close. Another question is, and this is the transverse, never close in this direction, close transversely. Longitudinal closure can cause stricture. So 2-layer closure can be done, single layer closure can be done. When I'm doing 2-layer closure, first is absorbable suture continuous, second is non-absorbable suture seromuscular interrupted, called Lambert suture. So that was a very old question. What are Lambert suture? Lambert suture is the second layer closure, interrupted seromuscular closure. Interrupted non-absorbable seromuscular, not through and through, only serosa, submucosa, you go. So what all question can be framed here? Number 1, as I said, this is the primary closure. Number 2, when the bowel is having multiple perforation or a long length is involved, I cannot do primary closure. Then I go for resection and osmosis. Number 3, when the bowel is very, very unhealthy, fragile, friable with a long segment, it's better to make a temporary ileostomy. Number 4, one more question they can frame. Patient having typhoid fever, having very severe pain abdomen for last 4 days, and now he comes in the emergency. In 3rd week of typhoid fever, patient can have bowel. 3rd week, remember 3rd week, and ileum. This is what perforate. So patient comes in emergency. It's a case of perforation. Now patient is in shock. He's in septicemic shock. Blood pressure 80/60. Temperature high. Tachycardia. And he's in shock due to perforation. Anesthetist has simply refused ki bhai, I cannot give anesthesia, ye patient mar jayega. And you cannot leave like this. So what you do? That's the last option we have. Put a drain in the abdomen. Local anesthesia, put a drain. And what the drain will do? All the I'm not saying in the bowel, I'm saying abdominal peritoneal cavity. All the collection you take out and hang a saline bottle, connect with the drain. So, aapne dhulai kar di, do a lavage. Under local anesthesia, it can be done. Just a small hole, put a drain, and so now you wash the abdomen, give antibiotic, give fluid. You can give vasopressin if required, norepinephrine, dopamine, whatever. Let the patient recover in few days, a few hours, not few days, he'll die in few days, in few hours or maybe next day, and then you operate. So all 4 possibilities are there. But if I give you one option, ki bhai perforation, what you do, you will say primary closure. All other are special cases where we go for this. Okay. For small bowel perforation, time is not the criteria. For esophagus, time is the criteria. For esophageal perforation, 24 hours is the golden period. For rectal perforation, again 24 hours. Within 12 hours, it's good. But for jejunum ileum perforation, time is no criteria. The bowel condition, more delay, more damaged bowel, more inflamed bowel. So I'm operating after 1 week. It's unlikely that I'll find a healthy bowel. But I can do primary closure if I find relatively healthy bowel. So time is no criteria, but delay will deteriorate the case. Okay. In case of and I cannot go at this speed, otherwise I'll go till 5. I had my OPD from 3 to 5. So I cancel my OPD, but at least I want to show my face and I want to do minor procedures. Some procedures are waiting. So I want to be there by 4:45. So I want to finish by 4:30. In case of retrocecal appendicitis, which movement aggravates pain? So this is an old AIMS question. For a simple perforation, we go for simple closure. So answer is extension. So, first of all, different position of appendix you have to remember. That was an INICT question 2 years back. Retrocecal is the most common, 60-65%. and post-ileal is rarest, less than 1%. The blood supply of appendix comes from appendicular artery, which is an end artery, a branch of ileocolic artery, and accessory appendicular artery can be there, called artery of Sheshachalam. It's a branch of posterior cecal artery, which is MCQ. The appendicitis can be obstructive type and catarrhal type. Obstructive type is more common and more complications. I'll discuss urology. Murphy's chart is a classical. Murphy's sign is sign of cholecystitis, tenderness in right hypochondrium. Murphy's chart is a chart of appendicitis. Pain, which starts here. The first pain here, then shifts to McBurney point. And pain, vomiting, and fever. The sequence should be like this only. Vomiting should never precede pain. Vomiting should always follow pain. So first pain, then vomiting, then fever. And the pain radiates from umbilicus to McBurney point due to inflammation from visceral to parietal peritoneum. Visceral peritoneum pain is felt at dermatome T10 umbilicus, and this is called visceral to somatic radiation. So from visceral umbilicus T10 dermatome to right fossa McBurney point. The signs of appendicitis are Robson sign, press on the left fossa, get pain in the right fossa. Cope-Swartz test for retrocecal appendix, extension of hip joint causes pain in right fossa. This has already been asked in AIIMS. Cope obturator test, internal rotation of thigh causes pain in right fossa. Aaron test, press on the right iliac fossa, get pain in the supraumbilical area. Edler test, mark the point of tenderness, change the position and re-examine. If the point of tenderness changes to new position with change of posture, this is not appendicitis. Means the change of posture, the tenderness point will shift in all other conditions except appendicitis. Rebound tenderness called Bloomberg sign, already we know that sign of peritonitis. Pain and coughing called Dunphy sign, already we know. The point is that this is confined to right fossa here. Bastedo test is an old test, obsolete test. It has been asked earlier 30 years back, so it's still given in guides. It's an obsolete test. Put a flatus tube, insufflate air in the rectum, patient gets pain in right fossa. Nobody does this anymore. In children, the most common DD is mesenteric adenitis, also called pseudoappendicitis, where the mesenteric lymph nodes are inflamed and enlarged, causing pain in right fossa caused by Yersinia, and fever is very high, much more than appendicitis. Investigation ultrasound is IOC. A tubular structure in right iliac fossa, blind ending, non-peristaltic, non-compressible is appendix. And how do you say it's appendicitis? Length more than 6 cm, width more than 6 mm is appendix. These two features tell you it is appendicitis. And target sign you do get. CT may show cecal bar sign and arrowhead sign. Although American Urological Association says MRI is superior to CT, but all over the world, including India, even love and belly, CT we do. Alvarado score, I want you to remember, this is easy to remember, this was last NICT also, Mantrel. 3 symptom, 3 sign, 2 investigation. Migratory pain, anorexia, nausea, always pain is the first symptom in appendicitis. Migratory pain, anorexia, nausea, vomiting, 111. Tenderness, only tenderness and leukocytosis, they get 2 number. Tenderness, rebound tenderness and elevated temperature and leukocytosis and shift to that means more immature cells. More than 7 is appendicitis. This you remember. Approach, clear-cut case of appendicitis, order appendectomy. What patient comes late? He may come with an appendicular lump which always forms after 48 hours. Neither the lump nor the abscess you will find within, I'm not saying exactly after 48 hours. You may find it 3rd, 4th, 5th, 6th, any day, but not within 48 hours. So, appendicular lump you get always after 48 hours, 3rd day, 4th day, 5th day. And though it's called appendicular lump, the lump is formed by omentum, and now surgery is not done. We follow conservative treatment called Osner-Sharon regime, and appendicectomy is done after 6 weeks called interval appendicectomy. So, in a question if lump is there, go for conservative treatment. If there is an abscess, collection near the appendix, only diagnosed by CT or ultrasound, then we go for percutaneous drainage. Or The word extraperitoneal is very important. You drain from outside, not laparoscopically, not by laparotomy, not from inside. So go for drainage. And if it's a perforated appendix, where how do you say it's perforated? The peritonitis feature is not confined to right iliac fossa. It's diffuse peritonitis all over the abdomen. So once patient has, and always seen within 48 hours. Why? Because after 48 hours a lump will form and the omentum will form a protective layer around it. So now even if perforate, it will not cause disseminated peritonitis. So it's seen in early cases, mainly obstructive type. Why children more common? Short omentum, it doesn't give protection, and old age because of the less immunity. And no, in hollow viscous you do get air below diaphragm, but you don't get air below diaphragm here because appendix doesn't have air, it has mucus. So perforated appendix is treated by laparotomy, not by a small incision. The appendicectomy incision, number 1, grid iron incision, oblique incision at appendix site. It's a muscle splitting incision. Number 2, Rutherford-Morrison incision. Now you can extend this incision laterally, called Rutherford-Morrison. That's a muscle cutting incision. Incision extended laterally. 3 muscles are encountered: external oblique, internal oblique, and transverse abdominis. So internal oblique is split and 2 other cut. Iliohypogastric nerve may get injured, which only in this incision get injured because it's muscle cutting, all other muscle splitting. So this nerve you have to preserve, otherwise patient may develop hernia later on. And a transverse incision, it mid-clavicular line, that's called Lance incision. Lance incision is a transverse incision, cosmetically better, again muscle splitting. Lance incision extended laterally is called Rocky-Davis incision, extended medially it's called Fowler-Weir incision. So this is a grid iron incision, McBurney. McBurney and grid iron are same. Extended laterally becomes Rutherford-Morrison muscle cutting, and a transverse incision Lance. Extended laterally it's called Rocky-Davis incision. Extend medially it's called Fowler-Weir incision. So these are the incisions of appendicectomy, in which first they ask which nerve is injured, iliohypogastric. Second they ask which incision can lead to hernia development, Rutherford-Morrison. And Rutherford-Morrison is muscle cutting, all other muscle splitting. A 10-year-old child presents with off and on bleeding per rectum. Technetium scan given below. So what's the diagnosis here? So yeah, McBurney and MacArthur are same. Although MacArthur is the right word, McBurney is not the right word. McBurney, anything related to appendix, we call it McBurney. But that incision was MacArthur. In Osner-Sharon, it's not some hi-fi new treatment. Osner-Sharon is a 70-80-year-old protocol. Simply IV fluid, antibiotic. Most important point is daily monitoring, charting, observation. TLC count, lump size, temperature, pulse rate. This close monitoring is called Osner-Sharon regime. So here this is Mickels and this is Mickels with ectopic tissue, which is why we go for resection and anastomosis. A normal Mickels without ectopic tissue can be treated by diverticulectomy. So another question, whenever you have a question, all these blue line are not questions in your paper, it's basically associated question. A 4-year-old boy, usually they present within 10 years, complaining of melena, bleeding per rectum is most common presentation due to ectopic gastric tissue. And whenever you find a outpouching or diverticulum from the ileum, this is Mickels. So this is Mickels. Now Mickels is the most common congenital anomaly. Persistence of proximal end of vitellointestinal duct. If vitellointestinal duct persists, diverticulectomy we only do when there is no ectopic tissue. Ectopic tissue there, then you do resection and anastomosis. Like this is the Mickels here, this is the ectopic tissue. If I cut and remove Mickels, ectopic tissue may be left behind. So you have to do resection and anastomosis. Without ectopic tissue, you can do diverticulectomy. So if vitellointestinal duct persists, then fecal matter will come out, which is a last year NEET question. Present at antemesenteric border. Rule of 2, 2% incidence, 2 inches long, 2 feet proximal to ileocecal junction. It has its own blood supply. Ectopic tissue are commonly found gastric and pancreatic. This is urine in the bladder. This is stomach parietal cell. This is MICOS. This M is MICOS. Now I want to remember this image. They show this is the intraoperative image. Yeah, all are in PDF form. All will be uploaded. The whole slide will be uploaded. So this is the MICOS intraoperative view, and this is the barium follow through. I want to remember this image. They don't ask directly image. Directly the question they ask, ki by intraoperative this finding was there. So what is this? This is MICOS. Now a patient presents with left iliac fossa pain. On examination, there was mild tenderness in left iliac fossa with palpable lump. What is this barium enema showing you? This is sawtooth appearance and diverticulosis and diverticulitis. So, diverticulosis is commonly seen in old age, most common in West. In India, high roughage diet prevents, it's protective. Involves only colon, although sigmoid is most common site due to high pressure, but whole colon may be involved. Diverticulosis presents with bleeding. The most common cause of colonic bleed is diverticulosis, but bleeding is from the right colon, which is why superior mesenteric artery is the main artery that bleeds. Left-sided diverticulum presents with diverticulitis, abscess, perforation, peritonitis, etc. Investigation for diverticulosis, do colonoscopy followed by barium enema, which shows sawtooth appearance, and for diverticulitis, CCT. These are the two pictures showing sawtooth appearance. This again is an important excerpt for you. Diverticulitis has a Henche classification. Abscess on the colon, type 1, away from colon, type 2, purulent peritonitis, type 3, and feculent peritonitis, type 4. So, 2, 3, 4 are treated in emergency by resection and Hartmann's procedure. One can be treated by drain the abscess and later on do resection and anastomosis. This again is a very favorite question nowadays. 30-year-old male presents with, whenever you have an opening by the side of anal version pus discharge, this is fistula in NO. So what is the, first of all they ask the diagnosis, second they ask the investigation. So MRI fistulogram today is the investigation of choice. And there's a Parkes classification, very, very important. This is the internal sphincter, this is external. Internal is circular muscle involuntary. So fistula going in between the sphincter is intersphincteric, most common type 45%. Through the sphincter is transsphincteric 30%. And this green line is the anorectal ring. Any fistula below this is low type and high type. Okay, let me do one thing. Let me take this higher so that it will be seen. It's not hidden by me. So, this 1 and 2, okay, let me delete this because okay. So, A is intersphincteric, most common, B is transsphincteric, C is suprasphincteric, and D is extrasphincteric. This you remember, this in between the sphincter A, through the sphincter B, and this line is anorectal ring, below this low type and above this high type. So, these are the perianal abscess and fistula, and low and high type are divided by anorectal ring. MRI fistulogram is the investigation of choice. Low type treated by fistulotomy, high type treated by CTON, and these are the three new treatment: WAFT, video assisted anal fistula treatment, lift, ligation of intersphincteric fistula tract, and FILAC, fistula laser closure. So, this is what fistula you need to know. Can you tell me answer of this question? A 55-year-old patient presents with 3-day history of right upper abdominal pain, fever and chills and right pain and diarrhea 1 week back. First tell me the diagnosis. 1 week back diarrhea and a double ring sign here. What is this? Diagnosis. Yeah, this is amoebic liver abscess because of three reasons. Number one, diarrhea and double ring sign. And why the answer is B? Why not just antibiotic? For amoebic abscess, treatment is antibiotic. The size more than 5 centimeter is the indication for drainage. No, it's not hydatid. Hydatid has a floating membrane, water lily sign, and multiple daughter says cartwheel appearance. Plus, hydatid is not related to fever, chills, rigor, and diarrhea. This is amoebic liver abscess. So, here, this is the double ring sign of amoebic abscess, and this is cluster sign of pyogenic abscess. Pyogenic abscess, main pathogen E. coli, and main root biliary infection, ascending cholangitis, biliary sepsis. So, pyogenic should be drained, while amoebic should be managed medically. Pyogenic are usually multiple, amoebic usually single. Pyogenic has cluster sign, amoebic have target or double ring sign. So, size more than 5 centimeter, non-responding, refractory for 5 days, impending rupture, volume more than 30 cc, and left lobe abscess, and other condition like pregnancy and immunocompromise. Here you have to drain the amoebic abscess. Otherwise, you manage amoebic abscess conservatively, medically. A 32-year-old lady underwent ultrasound examination and incidental following findings seen. Incidental. CBD diameter 3 millimeter. Incidental. What is the ideal treatment for her? Yes, you all are right. More than 5 is indication for drainage, which is why we should drain. And I'll go to one side so that you can see the picture more clearly. The answer is A. This is not a Phrygian cap, it's a stone. Phrygian cap is like this, gallbladder anatomically like this. So this is a gallbladder stone. Why it's not a polyp, and what's the approach? Dekho, let me first show you why it's a stone, why it's not a polyp. The stone has a caustic shadow here. Can you see the black line? Polyp does not have a caustic shadow. This is how you differentiate between stone and polyp. I will show you another picture of stone. So these are stone having caustic shadow. Number 2, how to decide the approach. Size less than 3 centimeter and asymptomatic. Simply keep under observation. This shadow is called acoustic shadow, which tells you it's stone. So, size less than 3 centimeter of the stone and asymptomatic, nothing to be done. But if the size is more than 3 centimeter or symptomatic, we will advise cholecystectomy. This is the answer had the size been bigger than 3 centimeter or symptomatic. Now comes why not MRCP, ERCP, etc. How you decide where we should order MRCP? It is mentioned here, the approach, and wall thickness more than 4 millimeter is also suggestive of cholecystitis, although not in this question, but otherwise. So, let's see the diagram here. Here I have some space, I'll draw it here. Liver, right and left hepatic, common hepatic, and gallbladder. When the stone is in gallbladder, it presents at cholecystitis. Answer B दिया है, you are absolutely correct. I'll get the answer corrected. Answer B दिया हुआ है, that's a wrong answer. वो इसलिए दिया हुआ है because the asymptomatic word was missed earlier. It is the question was patient came with pain and the ultrasound. So answer was that. But in the questions, the pain is removed, etc. If someone has changed the question, we do change the question off and on. So answer थोड़ा गड़बड़ हो गया. Answer should be A. So the stone is in the gallbladder. We do cholecystectomy. But anything in CBD, we must order MRCP before we do cholecystectomy. So CBD pathology, normally we don't get, but if we have to order. How we know CBD pathology? Two things. Ultrasound CBD dilated And what I mean by dilated? More than 6 millimeter is the abnormal size and more than 8 is the cutoff for MRCP. So what is the diameter? 3, which is normal. Number 2, jaundice. When the stone will be blocking here, this will lead to obstructive jaundice. So LFT should have bilirubin direct conjugated component high and alkaline phosphate is high. Then one should order MRCP before doing anything for gallbladder. So this is what's written here. If the CBD is dilated or LFT showing jaundice, how do you know jaundice? ALP high, GGT high and direct bilirubin high. So if ultrasound showing dilated CBD or obstructive jaundice LFT, then we order MRCP, otherwise there is no need. MRCP is not for gallstones. It's not that we order MRCP in all cases. No, MRCP is only ordered when we suspect CBD pathology by either dilated CBD on ultrasound or by LFT abnormal suggesting obstructive jaundice. So then we do MRCP. And if MRCP is showing CBD stone and gallstone or ultrasound showing CBD stone and gallstone, then you manage CBD stone first by ERCP, then go for cholecystectomy. Don't say I'll do gallbladder first and then I'll go for cholecystectomy. So 3 millimeter, more than 3 centimeter stone, even asymptomatic, should be removed. So CBD stone, MRCP is best and treated by ERCP, then you go for cholecystectomy. And so this is a normal MRCP, normal, no dye use. The white thing is just bile. Bile itself acts as a contrast. MRCP is a T2 weighted MRI. And first you order ultrasound and LFT in any pain in right upper abdomen. Ultrasound will show if there is a biliary type of colicky pain or jaundice or abnormal liver function suggesting obstructive jaundice by LFT, ALP and GGT with dilated bile duct, then you should order MRCP. Otherwise, there is no need of MRCP. And how do you know LFT obstructive jaundice? Conjugated bilirubin more, ALP more, GGT more, and theoretically 5-nucleotidase more, which we don't order in practice. And then order MRCP, then you decide what to do. MRCP is showing like here. What do you see here? You see a stone in CBD here. So in this case, I'll order first choledocholorectomy. Usually we do ERCP, we don't do surgery. So manage the CBD stone by ERCP and sphincterotomy, then go for cholecystectomy. Now let me read what I have written. What is cutoff cholecystectomy? 6 to 8 millimeter dilated CBD, then MRCP done or not, and CBD stone. Okay. So as I said, normal diameter of CBD is around less than 4 millimeter, 3 millimeter. But with age, CBD keeps on dilating. So at the age of 70 years, even 6 millimeter is fine, even 7 millimeter is fine. So although above 6 we consider abnormal, but we don't do MRCP less than 8. Above 8, we go for MRCP or symptom, biliary colic or jaundice or LFT abnormal. That's why not D? What is D here? No, there's no need to do regular LFT monitoring. You leave the stone, dietary modification. You can give chenodeoxycholic acid or ursodeoxycholic acid if you want. Whenever patient develops symptom, you go for cholecystectomy. One topic which is not mentioned here is not a question. That's choledochal cyst. I'll just briefly tell you about choledochal cyst. This is an important topic. Some topic I'll tell you which is not a part of question. Congenital cystic dilatation of CBD is choledochal cyst. It's a dilatation of CBD. Female more than male. Incidence 1 in 50,000, not needed. This part you can remove. Presentation, jaundice, lump and pain. Type 1, we excise and do Roux-en-Y, hepatocystostomy. This is a Tewari classification I want you to remember. Type 1 is just cystic dilatation, most common. This is more than 85%. Type 2 is a diverticulum. Type 3, choledochal. Type 4, intra-extrahepatic dilatation. type 5, 4B only extrahepatic, and type 5 is intrahepatic. Type 5 is also called Caroli's disease. Caroli's disease. Yes, if patient is in Charcot's triad or Reynolds pentad, you can directly go for ERCP because then it's kind of life-saving. Do ERCP and drain the CBD. For that we use the term decompression. So immediate ERCP and decompression can be done if it is Reynolds pentad or Charcot's triad. So this is the central dot sign of Caroli's disease, and these are two MRCP of Caroli's disease. This is Roux-en-Y hepatogenosmy. Miriam syndrome, the gallbladder stone presses the CBD and causes outside presses the CBD, causes obstructive jaundice. Yeah, Kasai for 4B and biliary atresia. Cholesterosis, or rather this image came in 2023 or 2022 INICT. This is cholesterosis. Cholesterol crystal gets deposited in the gallbladder, forming polyp and usually asymptomatic and managed. It's not an indication for surgery, called strawberry gallbladder cholesterosis, and this is only conservative. And adenomyomatosis, the mucosa dips down into the muscle. They go in the muscle forming RA sinus, Rokitansky of sinus. So adenomyomatosis, the mucosa proliferate hyperplasia into the muscle, forming Rokitansky of sinus. Muscle dystrophy can be there, cirrhosis is never involved. And in ultrasound, this gives comet tail sign. This also is managed. Adenomyomatosis and cholesterosis are not indication for surgery unless they're symptomatic, conservative. 3 angles of laparoscopy. Okay, again, I think I should take it higher up here. Azimuth angle is the angle between, this is the camera, we call it a scope, and I is the instrument. So angle between scope and instrument is azimuth angle. Angle between two instrument is manipulation angle. Angle between the table or the floor and the instrument is elevation angle. Elevation angle and manipulation angle should be 60 degree, azimuth angle should be 40 degree. So scope and instrument azimuth angle. This was asked recently, I think one of the other exams, probably in INICT or NEET, it was asked last year. And this triangle also is important, hepatocystic triangle. So liver, common hepatic and cystic duct. This is hepatocystic triangle. The question was, which is not a content, hepatic, cystic artery is not a content. Cystic artery, ये photo गलत है, just one word of caution, ये photo गलत है. Hepatic artery is not a branch of common hepatic, it's a branch of right hepatic. So this is the hepatic artery. Remember, it's a branch of right hepatic, it's not a branch of common hepatic as shown in the diagram. This is a wrong photo, and it's a content of hepatocystic triangle. Originally, only this was called Callot's triangle. This was called Callot's triangle, where cystic artery was a boundary. But now Callot's triangle and hepatocystic triangle are considered same. Central scarring is most commonly seen in which liver tumor? Can you answer this question? Central scarring seen in which liver tumor? Central scarring is seen in focal nodular hyperplasia. There's one more property, they do contain Kupffer cell, so they are hot on sulfur colloid scan. In sulfur colloid scan they are hot because they contain Kupffer cell. So these three are focal nodular hyperplasia having central scar. Central scar can be seen in HCC rarely. Central scar can be seen in fibrolamellar cancer rarely, but it's mainly seen in focal nodular hyperplasia. This is hemangioma. How to diagnose hemangioma on CT? In hemangioma, the contrast gets collected in the periphery and then move towards center. So we call it peripheral enhancement and centripetal flow. You can see here, look carefully, you can see contrast peripherally here and here in MRI, and then comes towards center. So central scar is a feature of FNH. Peripheral enhancement and centripetal flow is a feature of hemangioma. And how you diagnose HCC on CT scan? Triple phase CT or 4-phase CT is the IOC. When you give contrast in arterial phase, the tumor becomes hyperdense. Tumor becomes white in arterial phase, while the liver is not white. And when the liver becomes white in portal phase, in second, third and first phase, equilibrium phase, then the tumor becomes black. So early uptake and then it washes out. So as compared to liver, the tumor becomes white, and then when the liver becomes white, it becomes black. This is HCC. See here. The tumor is white here and the liver is not yet white. This is the arterial phase. And later on in portal phase and equilibrium phase, now the liver is white and tumor is black. Some capsule retain contrast, so they can give a ring enhancement capsule. So, and what about secondaries? How to differentiate secondary? Secondary will remain black throughout, hypodense. They don't take up contrast. So, in arterial phase black, in venous phase black, portal phase black. So, throughout and multiple hypodense area are secondaries. Multiple hypo. And a hyperdense area in arterial phase, and when the liver becomes white and this tumor becomes black, this is HCC. A patient 4 weeks after recovering from acute pancreatitis comes with complaint of upper abdominal mild pain, fullness and early satiety. I don't think there's any confusion here. This I do discuss in gland test and pancreas. I'm sure all of you can make a diagnosis. Can you make a diagnosis of this condition? Yeah. The answer is pseudocyst of pancreas. Pseudocyst, basically fluid comes out, gets collected and gets a fibrous wall. So pseudocyst is formed after 4 weeks with a fibrous wall, and if it persists, we drain it into the stomach after 6 weeks, called cystogastrostomy. That's the treatment of pseudocyst. Both hyper, I cannot read it from here. Yeah, hepatocystic triangle and calloid triangle theoretically differ. Hepatocystic triangle has a liver, common hepatic and cystic duct. Calloid triangle has hepatic artery, not liver, hepatic artery, common hepatic, cystic. So hepatic artery is a boundary in calloid triangle, which is a content in hepatocystic triangle, historically. But today we consider both as same. So after recovering for 4 weeks from pancreatitis, this is pseudocyst. Cystogastrostomy is the treatment after 6 weeks. Werner-Morrison syndrome is seen in VIPoma. I'm running short of time, so I'll go a little fast now. Endocrine tumor of pancreas, non-functioning is most common, but that's not option. We call it pancreatic polypeptidoma. Pancreatic polypeptidoma, but in functional, most common insulinoma. So, insulinoma are most common tumor, 90% benign, encapsulated, small, presents with Whipple striate, hypoglycemia, sugar less than 50, and you give sugar, it becomes normal. Gastrinoma, second most common, but in MEN1 syndrome, malignant and enteropancreatic, most common, it presents with Zollinger-Ellison triad, markedly elevated gastrin value, peptic ulcer, and non-beta cell. If you have a patient where the ulcer is not in first part stomach and first part duodenum in stomach, it is second part duodenum, third part duodenum, fourth part duodenum, or even jejunum. This is abnormal location of ulcer, refractory ulcer, extensive ulcer. This is Zollinger-Ellison syndrome gastrinoma. So this is ZE triad. It comes from first and second part called Passaro triangle. Passaro triangle formed by junction of CB2 with cystic duct, neck and body of pancreas, and second and third part duodenum. This Passaro triangle. VIPoma presents with WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria, and acidosis. And glucagonoma presents with dermatitis. Very common question, dermatitis in which endocrine tumor is glucagonoma. Question 13. What is question 13? The answer given in your book is B. As I said, that's a misprinting. Answer is A. If it is symptomatic or more than 3 centimeter, then the answer would be B. The answer will be corrected. Okay. So, glucagonoma presents with dermatitis and diarrhea and deep vein thrombosis, and somatostatinoma presents with diabetes mellitus and gallstone. This is the feature of necrolytic marrow. In pseudocyst, the wall forms in 4 weeks and surgery done after 6 weeks after the maturity. A wall will form at 4 weeks, but surgery we do after 6 weeks for the maturity. Then 6 weeks the wall become mature, become fibrous. This is also necrolytic magnetic edema. And this is an investigation for endocrine tumor of pancreas and carcinoid called SRS, somatostatin receptor scintigraphy, where we use indium, not inidium. This is misprinting. It's indium, INDIUM, indium 111 with octreotide, and you can locate the tumor. Treatment for all insuloma less than 2 centimeter, enucleation, more than 2 centimeter Whipples, and for body and tail, distal pancreatectomy. Identify the surgery. Can you identify the surgery quickly? Well, this is a sleeve gastrectomy along with Roux-en-Y. So, this is duodenal switch. So, what surgery you need to know in bariatric? Number 1, sleeve gastrectomy. This simple sleeve gastrectomy, just cut the stomach, convert in a banana shaped structure with a 32 French sleeve. And expected weight loss is 50 to 60 centimeter, BMI above 40, size of sleeve 32 French, most commonly done bariatric surgery. This is most commonly done surgery and reduces ghrelin. Weight GERD is the main problem, and leak is from here. Leak is from here. From the tip, here the staples are weak. This is sleeve gastrectomy. What is Roux-en-Y gastric bypass? Cut the stomach, make a small pouch of 20 cc and do a Roux-en-Y bypass. This is Roux-en-Y gastric bypass. The stomach is preserved. No part is removed. It's reversible. And the rule limb is 100 to 150 centimeter. These are the points you will get it. Most accepted, most commonly done surgery is sleeve gastrectomy. Most accepted surgery is Roux-en-Y gastric bypass. It's restrictive and malabsorptive both, but mainly very good balance. Peterson hernia is the main hernia complication, where the hernia happens behind the roux limb. Now, how to differentiate Roux-en-Y gastric bypass, BPD and duodenal switch? All 3 are Roux-en-Y. See, all 3 are Roux-en-Y. But in Roux-en-Y gastric bypass, no part of the stomach is removed. In BPD, distal gastrectomy done, and duodenal switch, sleeve gastrectomy done. So, if I am doing Roux-en-Y, preserving the stomach with a common channel of 100 to 150 centimeter, it's Roux-en-Y gastric bypass. If I am doing Roux-en-Y with distal gastrectomy with a common channel of 50 centimeter, very severe malabsorption, we don't do this surgery anymore, this is BPD. And if I do Roux-en-Y with sleeve gastrectomy with a common channel 100 centimeter, this is duodenal switch. And this is SARDS asked in INICT last week exam, where sleeve gastrectomy done, but not a Roux-en-Y, you take a loop here, and this is called SARDS. So, in SARDS, sleeve gastrectomy done, in Roux-en-Y, sleeve gastrectomy done, but in SARDS, we take a loop without Roux-en-Y, and in duodenal switch, we make Roux-en-Y. Here, the common channel is much longer, 250 centimeter. Here, the common channel 100 centimeter. This is the common channel, which is why the malabsorption is less in duodenal switch. Okay. So, in the question, SARDS was asked, while here it's a duodenal switch. This question is duodenal switch because Roux-en-Y done with sleeve gastrectomy. Some important X-rays for you. This is coffee bean sign of sigmoid volvulus. Single bubble sign gastric outlet obstruction, double bubble sign duodenal obstruction, and triple bubble sign jejunal obstruction. Multiple air fluid levels suggestive of small bowel obstruction. Apple core barium enema, cancer, and this is the clause sign of intussusception. This question, this photo was asked in last NEET exam 2024. This is a fundoplication 360-degree posterior called Nissen's fundoplication done for GERD, and this is a double duct sign where both the duct, pancreatic and bile duct, both are obstructed, both are dilated. It is mainly seen in periampullary cancer, rarely in cea head of pancreas. Now urology, quickly, a 35-year-old male presents with hematuria, hypertension and mild abdominal pain. So can you tell me what is the diagnosis here? What's the diagnosis? Yeah, answer is correct. Autosomal dominant polycystic kidney disease. You can see multiple cysts in the kidney as well as some cysts in the liver. So it's autosomal dominant polycystic kidney disease, and which has a PKD1. So the PKD1 on 16 and 4. Remember, autosomal dominant polycystic kidney disease 16 and 4. But autosomal recessive kidney disease, chromosome 6, which presents with cyst in kidney in neonate and liver fibrosis. Okay. So what are this is another CT scan. Remember, more than 2 cysts each one, both kidney having more than, although it differs with age, but simple funda, more than 2 cysts in each kidney, bilateral is polycystic kidney. What are the features we need to know? Chromosome 16 and 4, liver cyst, pancreas, spleen, ovary, all you get. You rarely get cyst in lung and never in testis. Diverticulosis is second most common finding. Berry and Riz, mitral valve prolapse syndrome are the features you get here. IVP show spider-like deformity, but we don't do IVP today. CT scan, non-contrast CT is IOC. Initially, you order ultrasound. Tolvaptan, which is a V2 receptor antagonist, is today drug of choice. And Rosing operation, we don't do anymore. It was done in past, it's obsolete surgery. We manage hypertension, diabetes, infection, and preserve the kidney as much as possible. Once kidney is gone, go for transplant. This is the X-ray, autosomal dominant cystic kidney. Dekho, some more congenital problem I'll tell you, other than polycystic kidney, 4-5 more. Dekho, whenever you have double system, bifid ureter, partial bifid or partial duplication is more common than complete. So this is more common than complete. And when there's a duplex system, complete bifid ureter or one ectopic ureter, on this you have MCQ. A young female having normal voiding and true incontinence. So she is having continence dribbling plus normal voiding. What is this? This is a ectopic ureter. One ureter opening here, filling the bladder, having normal voiding. Second opening here, causing incontinence. In male, ectopic ureter always open above the external sphincter. So in male, you never get incontinence. Only in female, you get incontinence in ectopic ureter. Then here we have a Wiegert-Mayer law, which says that the ureter will always cross like this. If there's a duplex system, ureter will cross. The lower opening may have ureterocele and the upper opening usually have vesico-ureteric reflux. Okay. In male, what is the most common site for ectopic ureter? Prostatic urethra. In male, what is the most common presentation? Recurrent UTI. But in female, incontinence. These are the questions you need to know. Another very congenital common anomaly asked routinely is horseshoe kidney. In horseshoe kidney, the lower pole is fused and it cannot go up, kidney cannot ascend, so it's present below the inferior mesenteric artery, which is why it's always ectopic. So remember, this is the horseshoe kidney and this is the seat. This image have come in exam where you can see both the kidneys are fused, horseshoe kidney. Horseshoe kidney lower pole are fused, male more common. Isthmus lies against L4 because ascent is tethered by inferior mesenteric artery. PUG obstruction is very commonly found here. IVP may show flower vase sign and prophylactic cystectomy has no advantage. These are the points I want you to remember. This is the horseshoe flower vase where the lower pole is directed medially. Lower calyx directed medially is flower vase. What is Potter syndrome? Potter syndrome is a condition of very severe oligohydramnios. No amniotic fluid, no lung development. Amniotic fluid is very important for lung development. So, renal agenesis, no urine produced, no amniotic fluid. So, that leads to Potter triad. Potter triad is pulmonary hyperplasia, Potter face, duplex is more common in female. Duplex as such, so flat face, big nose, low set ear, epicanthic fold. So flat face, limb anomaly, and pulmonary hyperplasia. This is called Potter syndrome. This is mainly due to oligohydramnios causing compression of the fetus. There is no amniotic fluid. So it has number 1, Potter face, number 2, pulmonary hyperplasia, number 3, limb deformity. This is called Potter triad, and Potter face has low set ear. Like see, it's basically flat face, compression, big nose, flat chin, low set ear. This is called prune belly syndrome or Eagle-Barrett syndrome. It was asked once. The muscles are practically absent or very weak. See the abdomen, atonic, wrinkled abdomen, no tone. And this is associated with vega bladder, reflux, and cryptorchidism. So, bladder contractility is not there, so child will not pass urine. There is a reflux, mega ureter, mega bladder, and absent abdominal muscle, and cryptorchidism. This is called triad syndrome or prune belly syndrome. A patient present with chronic pain in left flank, X-ray and CT images given below. Which statement is false about this condition? Can you make the diagnosis here? You can see this is a Staghorn calculus. Staghorn calculus is basically due to infection caused by Proteus. So these are right, this is wrong. What kind of crystal we get in phosphate? Coffin lid. So these points I want you to remember. Young, middle age is the age of presentation, male more than female. Infected stone are more common in female, but overall male more than female. Most common stone is calcium oxalate. 4 most common type are calcium oxalate. This is most common dihydrate. Monohydrate is very rare, that is hard stone, but dihydrate common. Infection steroid. This is the magnesium phosphate steroid stone. Uric acid, which is radiolucent, and cystine. These are the 4 main type. Calcium oxalate is called mulberry stone, small spiculated stone. Supersaturation crystallization is the method of stone formation, and uric acid forms in acidic urine. Phosphate forms in alkaline urine, mainly alkaline caused by urea splitting organism Proteus and Staghorn calculus. Calcium oxalate can form at any pH. Calcium oxalate does not require any pH. It can form at any pH. These are the crystals: hexagonal, cystine, calcium oxalate envelope shaped, triple phosphate coffin lid, and uric acid rhomboid or rosette. Monohydrate hourglass. So see, this is envelope shaped calcium oxalate dihydrate. This is coffin lid phosphate. This is cystine hexagonal. This is rhomboid. Either you find rhomboid, square, or needle shaped, that's uric acid, and this is bipyramidal or dumbbell. This is calcium oxalate monohydrate. They are hard stone, they don't break on lithotripsy. So this is calcium oxalate envelope shaped, coffin lid triple phosphate, and this is hexagonal, and this is uric acid, rhomboid and needle shaped. This is Staghorn. So types of stone: laxative abuse, ammonium urate stone. Malabsorption. Malabsorption and pyridoxine deficiency both have oxalate. The reason is very simple. More oxalate absorbed from the GIT causing hypoxaluria. This is a question that what finding you get in urine in any malabsorption: hyperoxaluria. More oxalate and more oxalate stone. Prolonged immobilization causes calcium phosphate stone. Ethylene glycol, this is the old question, causes calcium oxalate monohydrate. Renal tubular acidosis, again calcium stone because of low urine. Citrate is protective. That was a question of INICT. Hypercitriuria is actually protective, not causative. IBD, again calcium oxalate due to hyperoxaluria and uric acid due to acidic urine. How to treat a renal stone? Whenever there is a stone in the minor calyx here, we can leave it if asymptomatic or treat by ESWL or RIRS. RIRS is preferred for lower calyx stone. Stone in pelvis, less than 2 cm RIRS, more than 2 cm PCNL. And RIRS is retrograde intrarenal surgery done by, for less than 2 cm stone, done by flexible ureteroscope, and here you use holmium-Yaag laser stone laser. We do have a new laser, I'll tell you about that later on. So holmium-Yaag laser is used. Okay. This is a DJ stent, and if you see, you can see multiple stone along the DJ stent. This is if it's happening after ESWL. This phenomena is called stenosis. The lithotripsy breaks the stone and the fragments are big. They get collected, they pass into the ureter but get collected in ureter and form a line of a stone in ureter called stenosis. So stenosis is multiple stones stuck in the ureter, and that is basically a complication of ESWL. Option 3 here. In this question, PCNL is the treatment of choice for Staghorn calculus. It's a big stone, more than 2 cm. So that's the treatment. But hexagonal crystal you see in cystine stone, not in phosphate. Phosphate has coffin lid appearance. This photo was given in last NEET exam, and they asked how do you insert this. It's only inserted by cystoscopy. Let's say DJ stent. Simple DJ stent. Which of the following is not true about nephroblastoma? Nephroblastoma is a Wilms tumor. Wilms tumor has a blood-borne secondaries, that's correct. Wilms tumor treated by surgery, chemo, radio, that's correct. And most common intra-abdominal malignancy after the age of 2 years, that's correct. Before the age of 2 years, yes, treatment depends on size. Less than 2 cm go for ESWL or RIRS. More than 2 cm go for PCNL. So bone metastasis you don't get here, you get lung metastasis. B is the wrong option. So Wilms called nephroblastoma is the most common tumor of children between 2 to 6 years. Before 2 years, it's neuroblastoma. Develops from blastomal tissue, nephrogenic primitive kidney. It has a high risk with WAGR syndrome, Wilms tumor, aniridia, genitourinary abnormality, and mental retardation, chromosome 11p, band 13, and Beckwith-Weidman syndrome, chromosome 11p, band 15. Most common presentation is lump, which does not cross midline, and symptoms, general symptoms are very rare, like excessive crying, irritability, weight loss, anorexia. No, child is fine with a painless lump, not crossing midline. Lump crossing midline is neuroblastoma. CT is innocent choice. Known mets are very rare, blood-borne secondaries to lung, not to bone. And National Wilms tumor staging group and SIOP are 2 staging. Here, first you do surgery, then you stage, then chemotherapy. In SIOP, first give chemotherapy, then stage, and then do surgery. So in SIOP, first we give chemotherapy, then do staging, then surgery. While National Wilms tumor, first we do surgery, remove the cancer, and then do staging, then give chemotherapy. And this is a Claus sign of Wilms. Claus sign we get intussusception GIT in Wilms tumor. Claus sign is seen on CT scan. Advantage of bipolar cautery over unipolar cautery in TURP is. Can you answer this question? I'll wait for 1 minute. Advantage of bipolar over unipolar. The right answer is A, as most of you, all of you are writing. Saline can be used as a irrigating fluid. Let's understand the concept of TURP. देखो, ये है prostate. I will pass a resectoscope from here and cut the prostate from the bladder neck up to verumontanum. This green area is called verumontanum. Why we do not cut TURP syndrome is not the issue here, but yeah, that will be less, you are right. Why we don't cut proximal to verumontanum? Because this is the external sphincter. If I come proximal to verumontanum, proximal, because I am cutting from here, so this part is proximal, this is distal. We are cutting from outside. So if I come proximal to verumontanum, I can damage the sphincter and patient can become incontinent. So we have to be above verumontanum. This opening in verumontanum here in the center, these are the two lobes causing obstruction. This is verumontanum from the posterior wall. This is prostatic utricle. This is the remnant of paramucinous duct called Mullerian duct that forms uterus and female organs. So the remnant of Mullerian duct becomes prostatic utricle opening here. So this area I have to cut till verumontanum hole. This will be removed. So I'll pass a resectoscope, irrigate with the fluid and keep on cutting. I use unipolar, and this is the picture. Before surgery, all the lobe removed. This you have created this is the prostatic urethra, and this is after 3 months with epithelialization. The whole area is open. I use saline. The problem is saline has iron, so electric current will not cut. I use distilled water. Problem is hypoosmolar, water gets absorbed, causing dilution, hyponatremia, and which can be water intoxication, which can be life-threatening. So we use 5%, 1.5% glycine, which doesn't have iron. If I'm using bipolar cautery, then saline can be removed. Then saline can be used and easily prostate can be removed. So the advantage of bipolar, saline can be used. Now this is the Elix evacuator. Remember this instrument. Whatever fragment has gone in the bladder, you connect this to the resectoscope, irrigate with a saline or fluid, and this fragment will be washed out. You can take out the fragment from the bladder by Elix evacuator. What are the indications of surgery? Refractory retention, recurrent UTI, recurrent hematuria, bladder stone associated with BPH, not responding to medical treatment, or pressure very high during micturition. Normal pressure is around 40 to 60 centimeter water, more than 80 will cause reflux. That's indication. Peak flow rate in uroflowmetry less than 10 ml, suggesting again severe obstruction. Absolute indication are bladder decompensation, means chronic retention. The patient is not able to pass urine due to outlet obstruction, and the urine is residual urine volume is increasing. A time comes when the bladder gets grossly distended. Bladder capacity is 300, 400 ml, and now it is having 1 liter of urine due to chronic retention stage. Now patient comes with overflow incontinence. This is called chronic retention. Here, if we don't operate, put a caster, let the bladder become normal, drain all the urine, let the bladder become normal. With time, it will regain some strength. Then later on, you can do TURP. So this is one absolute indication, as well as reflux. Bilateral reflux due to high pressure is another indication. Remember, size of prostate and symptom are not a indication for surgery, nor they are related to symptom. So size of a 60 gram, normal volume is 20 cc, 20 gram weight. A 60 gram weight can be asymptomatic, while 20 gram can cause symptoms. So size does not matter as far as symptom is concerned or need of surgery is concerned. Number 2, residual urine also is not relevant and not an indication of surgery. TURP complications are bleeding earliest from Bedenox artery at 5 and 7 o'clock position, injury to ureter bladder, dilutional hyponatremia. If I use too much of diluted water like distilled water or any hypoosmolar substance, it gets absorbed. Sodium, once it goes below 125, patient will have symptom. And never ever correct the sodium rapidly. It will lead to central pontine myelonolysis, which we'll discuss in pediatric in medicine. So slow sodium correction should be done, which is why we use glycine where the hyponatremia is less. But glycine can get absorbed releasing ammonia in the liver can cause encephalopathy-like symptom, but this is transient. It disappears in a day or two without treatment. Retrograde ejaculation is the most common complication due to the damage to internal sphincter, bladder neck, and bladder neck complication. Contraction can also be there later on, which is treated by, once you do TURP, patient comes after 2 months and now he is having difficulty in passing, poor flow. What has happened? After surgery, the bladder neck has closed with scarring. So again, I have to put a sectoscope and cut the bladder neck called BNI with Collins knife. So bladder neck incision has to be done in case patient develops bladder neck contracture post-operatively, which is why for small prostate, we don't do TURP, we do TUIP, transurethral incision of prostate, because if I do TURP in a small prostate, the risk of fibrosis will be very high. Impotency, incontinence are other complication. Can you tell me what is this? What is this image? This is a question asked earlier. This is prostatic implants, radiation implant for the cancer treatment. Low dose radiation and high dose radiation. In low dose, we use iodine 125 and palladium 103, and in high dose, we use IR 192, iridium 192. CA prostate, you know, originates from the posterior lobe, locally and peripheral zone McNeil. Perrectal finding will be hard nodular prostate, mucosa fixed, median sulcus obliterated, and PSA more than 4 is considered abnormal, which requires further intervention, maybe some investigation, but more than 10 you should always take biopsy, suspect cancer. If PSA more than 4, go for MRI if possible, and MRI, we like you have BI-RADS in breast and TI-RADS in thyroid, you have PI-RADS in PI-RAD, more than 3 means biopsy. Or now you can order PSA density, PSA velocity, and free and bound PSA ratio. IOC for prostate cancer is MRI. Staging is important. I'll just tell you staging quickly. This is the prostate. Only on, first of all, what is T1? Only diagnosed after TURP in biopsy. No PR finding, PSA normal. It's biopsy says after TURP says it's cancer, it's T1, or PSA more than 10 is T1C. So only PSA high, no finding, or biopsy confirming is T1. One lobe involvement less than 50% is T1, T2A. One lobe involving more than 50% T2B. Both lobe involvement T2C. So one lobe within capsule less than half T1A, more than half T1B, and both lobe T1C. If it goes outside capsule, that is T3, seminal vascular involvement T3B, and surrounding structure other than seminal vascular T4. So any cancer less than 50% of one lobe is T2A, more than 50% T2B, and both lobe T2C. Outside capsule T3A, seminal vascular T3B. What is important is M. I want you to remember this. This will become a question one day. Metastasis M1. So any lymph node out. 3+4 is not staging. That is Gleason score. Gleason grade you have 1 to 5. I'll tell you. Let me finish this. So distant lymph node. If I give a question, para-aortic node involved, what is the stage? It is not N, it is M. So M1 is any node outside the pelvis. So lymph node distant in prostate cancer is M1, bone secondary is M2, and distant organ involvement M3. Prostate cancer has a tendency to go to bone, and vertebra and pelvis are the most common bone involved, and the bone secondaries are osteoblastic. Bone secondaries to the Betson plexus, internal vertebral plexus and periprostatic venous plexus have a direct communication. Bone secondary is osteoblastic. So ALP can come from liver or bone both. If GGT is also high, then that's a liver origin. Bone secondaries are treated by strontium 89 and radium 223. These are alpha emitting drug. So because these are osteoblastic secondary, these substance can be used. Not in other bone secondaries, only prostate osteoblastic secondaries. This is called radiopharmaceutical therapy. Prostate cancer and bone secondaries are radio and hormone sensitive, not chemosensitive. And a new treatment for prostate cancer, Sipuleucel T, called prostate vaccine. What you do, you take the antigen presenting cell, like dendritic cell, you take the prostate cancer cell, which are basically prostatic acid phosphatase antigen. So take the cell, take the dendritic cell, and in colony stimulating factor, grow them together, let them become significant volume, then inject to the patient. So you are basically culturing the antigen cell, making it significant, and inject to the patient, so the T cell immunity will work and destroy the tumor. Only done for castration resistant prostate cancer or hormone resistant prostate cancer. So Sipuleucel T is prostate vaccine. Treatment is less than 7 Gleason score, age old, observation more than 7 Gleason score, age less than 70, surgery. You have radiotherapy, chemo, radio, surgery, and hormone all. Chemo is not effective here. False statement about testicular tumor is 90% of germ cell tumor, seminoma, radiosensitive, extragonital have a poor prognosis. Most common tumor in young age of urology is testicular tumor. Testicular cancer, most common type is histological. Most common individual type is seminoma. Commonest tumor in old age is lymphoma in testes. These are all tested points. In children, 2-3-year-old children, most common yolk sac tumor. After puberty, teratoma. Overall, most common is seminoma. Remember this, most common seminoma. Before 6 months, glial cell tumor. And undescended testes, most common seminoma. But once you do testes and bring it down, orchidopexy surgery, then emerald cell cancer is most common. In hermaphrodite, gonadoblastoma. In intersex, intra-abdominal intersex testis, gonadoblastoma. And worst prognosis, hurricane tumor. What investigation you order? X-ray, ultrasound, scrotum, tumor marker, and CT. No FNSC, no biopsy. In tumor marker, we order AFP, beta HCG, and ALP. OCT3 is a new marker, but that's not for seminoma. That's not a new marker, that's not a blood marker, that's a histology marker, immunohistochemistry marker. Yeah, LDH. Third one is LDH, my fault. I'm getting, third one is LDH. ALP is for bone secondaries. LDH. So this is for non-seminomatous tumor. This is for choriocarcinoma. And this is for seminoma. Beta HCG can be seen in seminoma in 10% because 10% seminoma they produce in situ trophoblast. It comes from in situ trophoblast. FNSC biopsy never done. These three, ring K crystal in Leydig cell, you remember? Schiller-Duval body in yolk sac, you remember? And Karl-Exner body. Of course, this is discussed in gynae because this is for granulosa cell tumor and these are coffee bean nuclei. In the following picture, there is a butterfly-shaped hematoma. Butterfly-shaped hematoma. Where the urine get collected? The answer is C. Let's understand urethral injury. Dekho, the urethra is divided into 4 parts. This is the sphincter. This is the prostate. Prostatic, membranous, bulbous, and penile. Prostatic and membranous are called posterior urethra, bulbous and penile called anterior urethra. Yeah, AFP is never high in seminoma and choriocosma. In chorio, AFP is never high, seminoma never high. So, the posterior phalange 4 point you need to remember. What is the most common cause? Fracture pelvis. What sign you get? High floating sign called Vermeulen sign. Answer is C, of course. Vermeulen sign. Blood at meatus and patient not able to pass urine are common in both in posterior phalange as well as anterior. In anterior, there is a perineal trauma and butterfly shaped hematoma. Blood at meatus and not able to pass urine, common. So, whenever you have perineal trauma, think of anterior phalange. Whenever you have fracture pelvis and Vermeulen sign, think of posterior phalange. Posterior phalange means here. This is the posterior urethra, most common site of injury here. Membranous and bulbous junction. And anterior will be here. Now, what is the approach? First approach is just clinical. Blood at meatus, no blood at meatus. Although some people recommend that one should try a catheterization attempt at least once, that's not the standard teaching, standard practice. Blood at meatus means injury, although it's not a sure shot sign, but we go for, you don't want to increase the injury, so go for SPC, no blood at meatus, gentle catheterization. This is the first clinical approach. Second, if you have the facility of RGU, retrograde ureterogram, extravasation present suprapubic cystostomy, no extravasation catheter. Or the newest is flexible ureteroscope. If you have this facility, this is the best. If this is the answer, this is the best. Now here you can see fracture pelvis. See the here. Fracture pelvis here, here, and leak here. So normally the injury is between prostatic and membranous junction. Here. See another picture. Contrast study here. And pelvis has been fixed. And this is the extravasation from the bulbar urethra. So this is anterior urethral injury. In all these cases, SPC will be done. Now, this is the peritoneum. See this line. If the bladder ruptures here, this is intraperitoneal rupture of the bladder, and which is 20%. Flame sign you get in cystogram, and immediate repair should be done. If the rupture is here, here in this space, this is extraperitoneal rupture, and here 80%, and here surgery is not always needed, only catheterization and it heals. If the injury is here, here, this is the posterior injury here, this is anterior, and in anterior the collection will be here, where I'm putting the black color here, between Buck's fascia and Colles fascia. This is the question, and this is the concept. I'm going little fast because I'm running short of time. So answer is of course 3. Butterfly shape means anterior urethral injury, and here this. Okay, bulbar urethral injury, exactly, bulbar urethral injury. So that's the last question. Some extra point. Dekho, this is a new surgery for incontinence, stress incontinence, called TFT or TOT. In general, we call it sling operation. TVT and TOT. What we do, it's not a major operation. A sling is placed behind the urethra, making the angle narrow, sharp, and it is transvaginal or transobturator. So two methods: tension-free vaginal tape, transvaginal, and transobturator. TVT and TOT sling operations done for stress incontinence. Remember the name, it may become AMCQ. Number 2, a new method to take prostate biopsy. We are taking TRUS, transrectal ultrasound. Now we have transperineal template prostate biopsy. Like if I take the biopsy from the rectum, that TRUS. If I take from the perineum, that's TPTPB. The advantage is we can take 36 biopsy rather than 12 that we take in TRUS, and we can take from the anterior prostate segment also, which is not possible by TRUS. Although this requires general anesthesia done in the operation theatre, which is why it is not superior to TRUS even today, but this is a new method to take prostate biopsy. Number 3, PSMA PET-CT today is a investigation of choice for prostate secondaries. Prostate PSA nahi, PSMA, prostate specific membrane antigen. PSA is released in blood, so it's done by blood investigation. A serine protease, liquefaction of serum is the main job, and this is a membrane protein, so it's only seen on investigation. Gallium-68 PSMA PET-CT. This is being done in India, so this is the new investigation for secondaries. Although fluciclovin and pliflofolostat has been approved but not used in India. New laser we are using. We are using only 2 lasers: holmium laser and KTP laser. KTP is potassium titanyl phosphate, called green laser. KTP only used for prostate, while holmium is used for stone and prostate both. But this is a new laser, thulium fiber laser, becoming very popular now. Wavelength is 1940, which is closer to water absorption, so it's better, and it breaks the stone with a much smaller fragment, and a smaller fiber is needed, so RIRS can be done by a smaller instrument. So RIRS, a smaller fragment, and you can do like whole and whole lumen laser enucleation and vaporization, same you do here. More time, no tissue for histology, more post-op irritative symptom. This is the disadvantage. And remember, anticoagulant need not be stopped for laser surgery. Patient on anticoagulant, you want to do this, you can very well go ahead without stopping the anticoagulant. This photo, they do ask an exam, ectopia vesicae, extrophy of bladder with pubic diastasis. For pubic symphysis reconstruction, ileal osteotomy is done. Targeted alpha therapy for prostate cancer, just now I told you. Okay, this is another picture of ectopia vesicae, and here we have adenocarcinoma. 3 abdominal wall defect, umbilical hernia major, omphalocele coming out from umbilicus with a sac, gastroschisis, intestine coming out right of the umbilicus with an intact umbilicus, and ectopia vesicae. Testicular torsion common in teenage, intravaginal more common. I'll just show you the image. This is called Clapper belt deformity. High invagination of tunica vaginalis. So testis hangs like this and undergo rotation. Intravaginal is more common, seen mostly. This is extravaginal, only seen very young children, and here bilateral fixation needed. Both testes needs to be fixed. This is testicular torsion, normal testis. This is somewhat gangrene, and this is completely gangrene. If you have the third image, you have to go for orchidectomy. Blue dot sign of torsion you don't get in testicular torsion, you get in appendix of testis torsion, appendix of testis like this, and this is managed conservatively, blue dot sign. This is emphysematous pyelonephritis caused by E. coli, air in the kidney, E. coli, and this is xanthochronic pyelonephritis, Beer-Post sign seen associated with stone and proteus infection. This is the posterior valve, only seen in male, type 1 is most common, and this is the MCU, and this is the keyhole sign on ultrasound. These photos you have to remember. Gibson incision is given for renal transplant. Fournier gangrene, another commonly asked question. Synergistic infection, aerobic, anaerobic bacteria. The testis is never involved. Tunica albuginea acts as a protective membrane. So do debridement, give antibiotic, never do orchidectomy. You can do shameless exposure of testis which can be implanted in thigh, no orchidectomy. Malakoplakia is a condition where the phagocytose WBC cannot destroy the bacteria due to lysosomal enzyme deficiency. So they simply ask what is malakoplakia? Due to defective phagolysosomal activity, and von Hansenmann cell and Michaelis glutamin bodies you get here. Only theoretically they ask. This is medullary sponge kidney, bouquet of flower sign. Christmas tree appearance, neurogenic bladder. Spider head deformity, autosomal dominant kidney disease. Adder head or cobra head sign in uretrocele here. DJ stent already you know. Drooping lily sign seen in duplexus kidney, the upper pole, compressor lower pole, and the calyx are directed downward rather than laterally. Retrocaval ureter, the ureter going behind the vena cava, giving a fish hook appearance. Maiden waist deformity, like this maiden waist deformity. Both the ureter are close to each other at the T4L1 level, seen in Ormond's disease, retroperitoneal fibrosis. Flame sign seen in intraperitoneal rupture of bladder. String of pearl appearance in the renal artery seen in fibromuscular dysplasia causing renovascular hypertension. Hutch diavertlum is not important, but one question was there. It's only seen in bladder in males. It's an incidental finding, asymptomatic. There's a diavertlum on either side of bladder, by the side of ureteric orifice. Page kidney is hypertension caused by kidney due to extrinsic. Renal hypertension is due to renin production, and that's due to ischemia, but it's due to extrinsic pressure. Something pressing the kidney can induce that renin production. So by external pressure, there is a hypertension by kidney called page kidney. Tuberculosis में 4 signs I want you to remember. One is putty kidney, and whenever you have aseptic pyuria, WBC in the urine and no bacteria, first ready should be tuberculosis. So calcified or cement kidney or putty kidney, a thimble small bladder, goal-fold ureter. Normal ureter has a submucosal course and a volcano-shaped appearance. This is the goal-fold ureter here, which is a question last year, and around the ureter, pallor and tubercles. This is very suggestive of in the bladder, very suggestive of tuberculosis. So these are some of the important points. Of course, I had very limited time, so I had to go a little fast. And this is a message for you. You are braver than you believe, stronger than you think, and smarter than you see. So, sterile pyuria suggests tuberculosis, not diagnostic. Sterile pyuria you do get in analgesic nephropathy, in cancer, in many other conditions. Sterile pyuria, thimble bladder, and putty kidney, definitely tuberculosis. So it's already too late for me. I have to run now. So I have tried to compile some important topic for you and photos. Of course, if I had time, I could have discussed it in detail, like approach and everything. Following TURP biopsy shows CA prostate. Yeah, this is what we do. Just 2-line twinkle. If the biopsy is less than 5% of the volume, Gleason score less than 7, age more than 70, old person Gleason score less than 7, observation. If the Gleason score 8, 9, 10 or age young, then go for further surgery. Usually we give radiotherapy or hormone therapy. देखो urology के लिए you can ask on telegram, although I admit I am very irregular, but now your NEET exam is very near, so I'll try to be regular. On from 6 to 12 I'm out of India. Before 6 I'll try to answer all your query, so you can post your query on this Instagram. तो मैं यूज नहीं करता, टेलीग्राम पे डैम्स के ग्रुप में आप डाल सकते हो, ठीक है. So I think I'll stop the stream now.